welcome to this explainer. Today, we're diving straight into the exact mathematical formulas we use to safely medicate pediatric patients. If you work in healthcare, you already know that dosing a child isn't just guesswork, it's a precise science with literally life-or-death stakes. So let's break down the math that prevents those catastrophic errors.
Here's our roadmap. We're going to cover why these formulas actually matter, dig into the age-based rules, look at weight and BSA methods, compare them in practice, and finally, lock down the safest clinical approach.
Okay, Section 1. Why pediatric formulas matter.
It's a super common question from the general public, right? Why can't we just cut an adult dose in half? Well, you can never, ever just have an adult dose for a child, and here is exactly why.
It all comes down to pathophysiology. Kids are not just miniature adults. Their physiology is a whole different ballgame. Their liver enzymes are immature, so drug breakdown is way slower. Their kidney filtration, specifically the GFR, is totally underdeveloped, which keeps drugs circulating in the blood for much longer. Throw in a higher percentage of total body water, and the danger becomes crystal clear. If you give a kid an adult dose, or even some arbitrarily half dose, that drug is going to build up fast, risking severe, life-threatening toxicity.
Because of those immature organs, our margin for error is razor thin. Even the tiniest mathematical slip-up can be disastrous, and that is exactly why we rely so heavily on strict, standardized formulas.
Moving on to Section 2, age-based dosing rules. First up, we've got Young's rule. This is one of the classic age-based formulas. It uses the child's current age in years to create a fraction of the adult dose. You literally just take the kid's age, divide it by their age plus 12, and then multiply that fraction by the standard adult dose. Now, why do we use this? Well, it's all about liver enzyme activity. As an older child gets closer to adult physiology, their liver matures. Young's rule gracefully adjusts for that developmental maturity, safely allowing a proportionally larger dose as those organs get better at metabolizing. Next up is Cowling's rule, which takes a slightly different angle. It actually asks for the child's age at their next birthday, divides that by 24, and then multiplies by the adult dose.
This is actually pretty clever. By anticipating that next birthday, Cowling's explicitly accounts for those rapid childhood growth spurts we see early on. By looking ahead to the next year of physiological capacity, it often gives us a slightly safer, more conservative estimate than Young's rule.
And then, for our absolute most fragile patients, we have Fry's rule. Here, we toss out years entirely. We measure age strictly in months, divide by 150, and multiply by the adult dose.
The big takeaway here is that Fry's rule is reserved exclusively for infants under 1 year old. Why? Because their enzymatic drug metabolism is remarkably low. If you used an age in years formula for a 6-month-old, you'd risk catastrophic toxicity. So Fry's rule drastically scales down that adult dose to protect those super-sensitive developing organs.
All right, Section 3, weight and BSA methods.
Age is helpful, sure, but let's see what happens when we introduce more precise physical metrics. When you compare the two side by side, age is really just an average. It assumes the kid is growing perfectly on some standard curve. But a child's actual weight? That tells us exactly how much physical space a drug actually has to distribute into. It grounds the math in physical reality.
Which brings us to Clark's rule. Look at how this shifts the paradigm. It drops age completely. Instead, you take the child's actual weight in pounds, divide it by an assumed average adult weight of 150 pounds, and multiply by the adult dose.
By relying on actual body mass, Clark's rule is fantastic at preventing accidental overdoses. Think about a child who's older chronologically, but maybe falls into a much lower weight percentile due to genetics or illness. An age-based rule might overdose them, right? But Clark's rule safely scales that med to their actual volume of distribution.
And then we arrive at the absolute gold standard, the body surface area, or BSA method. This formula takes the child's BSA in square meters, divides it by 1.73, which is the average adult BSA, and multiplies it by the adult dose.
BSA is basically the peak of pediatric dosing. It doesn't just measure how heavy a child is. It closely aligns with their actual physiological activity. We're talking metabolism, renal function, cardiac output. All of those correlate way better with surface area than with just straight weight. It is incredibly reliable.
So, Section 4, comparing formulas in practice. Let's take all this theory, pull it off the textbook page, and put it to the ultimate mathematical test. Say we have an 8-year-old child who needs a standard 15 milligram adult dose. Let's run that exact same scenario through both Young's and Cowling's age-based rules. For Young's, it's 8 over 20 times 15. For Cowling's, anticipating the 9th birthday, it's 9 over 24 times 15.
Wow, look at that difference. Young's gives us exactly 6 milligrams, while Cowling's yields a more conservative 5.625 milligrams for the exact same kid. And hey, this isn't just a rounding error. With potent medications that have super narrow safety margins, think digoxin or insulin, that tiny fraction of a milligram can literally mean the difference between a therapeutic cure and dangerous toxicity.
Which leads us nicely into Section 5, the safest clinical approach.
Seeing those conflicting numbers side by side really drives home our final takeaway. Because of the natural variability and the huge assumptions baked into age-based math, weight and body surface area have become the undeniable gold standards in modern medicine. They strip away the guesswork of average development and focus purely on the physical reality of the child right in front of you.
We know kids react more violently to medications, right? Their metabolism is just too unpredictable. So with that therapeutic window being so incredibly narrow, the question you've got to ask yourself is, are you trusting the absolute safest variable for your patient? Are you relying on an average, or are you measuring reality? Keep that in mind the next time you're reviewing a pediatric dose. Thanks for joining me on this explainer, and definitely keep questioning the math behind the medicine.